trick is to introduce as deep as possible a guide wire so that you have a firm platform to place your stent. So the guide wire is now inserted, and as I said, you push as deep as possible. And after you've done that, then you will put in your this stent, the pre-deployed stent. The stents that comes in are usually about 10 French, so they will go through a channel as long as it's more than 3.2 millimeters. So you can use a double T scopes or even the ERCP scope for that matter, because the accessory channel of both scopes are definitely wide enough for a 10 French delivery system. So this is the delivery system of the stent. So once you have placed a guide wire deep inside, you push in the delivery system. The other point to note is that when you use stents, you have to be familiar with the stents, because various companies come up with various stents, and this distal part here, the proximal part here, may vary among different companies. The number of radio opaque markers on the stent is also varies among the different companies. So you have to be familiar with the stent that you have chosen for that particular patient, because you do not want a scenario where you deploy a stent and then it is not ideally deployed and you end up either readjusting the stent or placing a second stent to overlap the first stent. So this is the delivery system that you see fluoroscopically. So once I push it past the obstruction, then now you can use endoscopic view to guide your deployment. So the nurse will then deploy the stents and you will adjust the scopes accordingly, so that at the end of the deployment, your position will be ideal like this. So the stent is placed at the proximal end of the stent, is usually a few centimeters proximal to the tumor obstruction, so that you can achieve success in the relief of the obstruction, like this. Okay, so this is the basic stents. I think subsequently there's no need to show anymore, because this is the same whether you are doing it for esophagus, for colonic, or for the pyloric. Okay, so in order to avoid complications, remember, patient can aspirate. So make sure if any fluid, you aspirate the fluid. Some people are worried that if you place an upper esophageal stent, you may actually press against the airway, may compromise. So if you are worried about that, if the tumor has been seen to compress against the trachea from the CT, you may want to test that they put in a balloon catheter, blow out the balloon to the same diameter, and then you wait for a while. If the patient does not start to have stridor, you can probably safely continue to place the stent. Okay, be familiar with the device, and remember, use a Baltic catheter and a floppy tip guide wire. Okay. So what happens if you, after placing the stent, you are not happy with the position, or you want to retrieve the stent subsequently? So many of these stents now comes with lasso, this bluish tinge here or the whitish tinge here. So if you see the lasso, you can actually adjust the stent. So this is the stent here, it's a covered stent, and this is the lasso here, so it's like a purse string. So when you pull the purse string, the whole proximal end of the stent will collapse and close up, so that you can safely pull out the stent without traumatizing the lumen of this patient. So the lasso. But remember that stents can also fracture, and there have been a few case studies of fracture of the stents, and this happens to one of my patients that we placed a stent for actually a benign esophageal stricture after much discussion and explanation. And you can see down here that the stent, the distal part of the stent has actually migrated into the stomach. Well, we managed to retrieve the stent, it's not a problem, but it's just to tell you that this possibility exists, and that is fracture of a stent. There you are. So the stent is fractured right here like this. Amazing. It's only about 1 year plus of deployment. And the next one is, I said, you can use a covered stents to close up a fistula, especially the tracheoesophageal fistula. This guy has lots of empyema due to the leakage, and it's been proven by this gastrographing swallow. And then endoscopically, you see a fistula here, and we place a covered stent, a ultraflex stent, and the lung became resolved, the pneumonia and empyema resolved after we placed the stent. Okay. And this is the upper esophageal stenosis. This is a very tricky area to place a stent, because if you place too high, like this, you're going to compromise the airway, or you may cause lots of discomfort in the throat of the patient. It is very uncomfortable, and patient usually will want you to pull up. So it is very tricky to place a stent very high up, especially near the upper esophageal sphincter. And if you do so, then you might want to actually use a cervical esophageal stent. As you can see, most of the time it is under fluoroscopy guidance, because to see endoscopically at the throat and upper part here is actually very traumatic for the patient who will keep on gagging. So this is the cervical esophageal stent here. What is the difference? The difference is that the top part here is very funnel with an obtuse angle compared to the distal end. So supposedly this would then therefore not cause so much discomfort and compression on the upper part of the patient, so that he can tolerate this stent deployment. And I have published experience of using these cervical esophageal stents, and the patient actually responded as even up to 1.5 to 2 cm away from the upper esophageal sphincter, as long as you use the cervical esophageal stent. Okay, colonic stents, we know if you do an emergency surgery compared to elective, of course the morbidity and mortality will be higher. So we prefer to place a stent so that you can do it into a one-stage procedure. You place a stent, you relieve the obstructions, patients get better, patients are stable, the surgeon go in and then do a one-time surgery rather than two-step surgery. So again, technically it's 90% success rate and clinical success of 90%, but the perforation rate tends to be a little bit higher as compared to esophageal stenting. You can have problems in early stage after stenting of the colon because of the tumor that is very tight, or because you didn't deploy adequately, or because there's an additional tumor proximal to it, or because the stent migrate, or because there is a long stricture, or last but not least, fecal impaction. The next stage will include hyperplastic stricture or tumor ingrowth, tumor overgrowth, which is the same as for any other lumen obstruction. Small bowel stenting, technically it is possible through the DB, double balloon enteroscopy, but it's not easy. You can't do it through the scope because the lumen of the double balloon enteroscope is not wide enough to place a 10 French delivery system. So basically you push your overtube all the way to the tip, the proximal end of the obstruction. You put in the guide wire, you withdraw the scope, and then you may actually attempt to put in the delivery system. But remember that the overtube is at least 145 cm long, so you may need to cut off the overtube. But remember that your balloon should be deflated when you cut off, otherwise there's a problem with the air supply line to the overtube. Okay. So because of all this, when you place the stents and for benign strictures, for fistula, we need to remove them. So if you put in the covered stents, you can remove it easily, but they migrate easily too. You put in the uncovered stents, they don't migrate, but you're going to have problems trying to pull out the stent. Partially covered stents perhaps may answer this question, but then again, it's not foolproof. The tumor may still grow into the uncovered portions at the ends. So people have now come up with this attempt to obviate the need to remove the stent, and using a biodegradable stent made of poly-L lactic acid monofilament. But in these early studies, 77% migrated after up to 3 weeks. And this is one of the latest biodegradable stent, SX-ELA esophageal stent. It is made of this polydioxazone. It is partially absorbable, partially secretable, and once you deploy, after 4 to 5 weeks, you start to degrade, and it's definitely as efficacious as a polyflex stent. You do not need to remove, it looks promising. Only 9.5% migrated, but all of them dissolved after 6 months. So more and more studies are being conducted to evaluate the long-term usefulness of these biodegradable stents. And this is the stents here that you deploy, and after you subsequently perform endoscopy, you can see that it actually degrades until it disappears, totally resolved. Okay. Last but not least will be lumen opposing stents, metallic stents. So basically, they create anastomosis between two non-adherent organs, for example, the gallbladder and the duodenum. So it generates force enough to hold them together, oppose them together, reduce the risk of leakage, prevent migration, and offers you a portal of access to target the organ if you need to repeat the interventions, for example, putting a scope through the stent into a pseudocyst to do necrosis, necrotic tissues removal. So there are a few types in the market. The one is from Axial stents, and the other one is the Nagi stents from Taewoong. And this is acknowledgement of the use of these videos from ASGE library. Kenneth B. Moeller and Toy have been very active in using this doing research on lumen opposing stents. So basically, once you identify the gallbladder that has been obstructed and the patient is not fit for surgery somehow, you can actually puncture the gallbladder with a FNA needle. And once you puncture the needle, you put in a long guide wire within the gallbladder. In this case, it's from the duodenum to the gallbladder. And after you put in the guide wire, you push in these stents, the lumen opposing stents. So you see, once you put in, you deploy the stent slowly, the inner part will open up like a balloon, and then you need to pull back again to make sure that when you deploy the proximal end, it is outside the gallbladder, not inside the gallbladder. So that's the only thing that you have to remember when you want to use a lumen opposing stent. So this is the lumen here, in the proximal end of the stent, between the duodenum and the gallbladder. So this is very exciting, and I think we are doing more and more studies on this. So basically, if you want to do this type of lumen opposing stents, then you have to at least have good knowledge and experience in EUS, and preferably also ERCP, because you may need to use some accessories to dilate, etc. So it is promising to relieve obstructed or purulent gallbladder, or for pancreatic cirrhosis, fluid collection, perigastric abscess, and even people have actually done it for obstructed duodenum, so they actually do it from the stomach to the jejunum to create an anastomosis. So ladies and gentlemen, in conclusion, I think you will agree that endoluminal stent is safe, is efficacious, definitely cheaper compared to a palliative surgery, shorter stay in the hospital. In fact, most of the procedures can be done within 15 minutes and improves the quality of life. I think we are still waiting for more data on the RCT between covered stents and these SCPS for benign strictures. So more and more people are using for benign strictures, and with that comes a new set of problems, and that is migration and removal of the stents. And last but not least, we are now doing more and more studies on this exciting aspect of biodegradable and lumen opposing stents. So with that, I end my lecture. And this is Bagan, which I visited after my last meeting in Myanmar. Thank you very much.
Thank you, Dr. Jayampon, for your excellent presentation for the stent in the GN Trust. We have a little time, so we can allow the one question from the audience. Professor Randy, please.
Thank you very much for the very interesting talks talking about. I'd like to ask one question. Sometimes we came across with the recurrence of the gastric cancer with the GJ stomach, operator stomach. In that case, what types of stents we have to use for the obstructed stoma? Thank you very much.
Obstructed stoma, you mean a stoma? The patient has a stoma?
GJ stomach, GJ. Post-GJ stomach. Gastrojejunostomy, operator stomach.
So it will be a gastrojejunum. So the anastomosis is tumor.
Yeah.
You can play. But if there's a recurrence of tumor and the patient is not a candidate for repeat surgery, then obviously you can put in a stent. In that case, you can actually place an uncovered stent, because I don't think you want to remove the stent. It's going to be permanent. But having said that, if you put in an uncovered stent, the chance of tumor ingrowth will be faster, will be higher. So in this case, you may want to consider a partially covered stent too. So there are a few options that you may consider. Because there is a recurrence and a stricture down there, the chance of migration, I believe, will be actually not that high. So I think a partially covered stent or an uncovered stent will be appropriate. But I will not put in a totally covered stent, because it may migrate. The Taewoon has come up with this new combi stents, which is a very wide diameter, and it is covered, but yet the chance of migration is supposed to be low. So you may also want to read up more about this combi stent from Taewoon.
Thank you, Professor Jayampon, for your very excellent presentation. Shall we move to the third speaker? The third speaker is Professor Anyam King, the Division of Gastroenterology, Department of Internal Medicine, School of Medicine, Catholic University of Daegu, Korea. Professor King will discuss about EUS and subepithelial lesion. In recently, we have a lot of indication for EUS, but among these indications, Professor King will only tackle rural EUS and subepithelial lesion. Professor Kim, please.
Thank you, Mr. Chairman, for kind introduction. Good morning, ladies and gentlemen. I'm very honored to be invited in this wonderful meeting. I would like to express my sincere appreciation to the organizing committee, including Dr. Mo. It is my first trip to Myanmar, and it's a really nice place. I think before the meeting I visited Bagan. It was a fantastic place. And the one more best thing here in Myanmar is I can meet so many women doctors here. It is fantastic too. And the topic of my talk today is US in subepithelial lesions. As Dr. said, there are many indications of US, but my talk is limited to subepithelial lesion today. Previously, the term submucosal tumor was frequently used, but the lesion may not be in submucosal layer and it may not be a tumor. So recently, we are using the term subepithelial lesion. Subepithelial lesion means a mass-like protrusion that is covered by normal mucosa. Usually, it is found incidentally during endoscopy or barium study. The lesion may be intraluminal or extraluminal. It may be neoplastic or it may be non-neoplastic. Subepithelial lesion intramural area may be located in different position and it may be differently treated. Extraluminal lesions may be normal structure or any pathologic lesions. When we want to examine subepithelial lesion, there are two important positions. We should examine transition zone and overlying layers. Transition zone means the area where the normal wall layers are merging into the lesion. To see the overlying layers, we should make perpendicular imaging. It is very important. And the transducer should be positioned on the top of the lesion to demonstrate the